right, I think everyone is ready to go now. I'm just going to hand over to Estian and he can do the introductions.
Good afternoon, everyone, and welcome to this lecture. My name is Estian Mallet, and I'm a third-year MB-CHB student and the head of the Academic Development Committee. So today, we will be finding out what it takes to become a surgical registrar, and we will be looking at what you can do to build your CV and what the requirements are for becoming a surgical registrar with regards to exams and certifications. And who better to present this topic than our very own Professor Martin Bryant, who is an associate professor, head of the Hepatopancreaticobiliary Surgery, and chairman of the PhD committee at the University of Pretoria. He is also the current secretary of the College of Surgeons of South Africa and chairman of the Federation of Surgeons of South Africa. Lastly, and definitely not the least, Dr. Yonita Singh will provide us with a professional perspective on what being a surgical registrar entails. She is a final year general surgery registrar at Steve Biko. She received the MB-CHB degree cum laude at UP and also passed both her FSC primary and intermediate cum laude and received the Brepner Award for the best performance in the country in 2020 for FSC intermediate. So before we start the lecture, I just want to ask that you keep yourselves muted and your camera off for the duration of the lecture. We will give an opportunity for questions at the end of the lecture. And finally, we will share a Google form with you, and we would really appreciate it if you can give us some feedback using this form. So without further ado, I hand over to Prof. Martin Bryant.
Thank you very much for that generous introduction. You guys are going to be sharing my presentation, so I'll just wait for that.
Can you guys see the screen? For me, it's on agenda.
Yes, I can see it as well.
Okay, I can't see it. That's weird. For me, it's a blank.
Ruben, can you also see it? It seems like everyone can see it besides you.
Oh, that's amazing. I can't see my own presentation. Okay, you know what I'll do? Let me just open my own presentation and let me split the screen. That's bizarre. I've never had that before. Never done that. Okay. Okay, fine. You're on the agenda screen?
Yes.
Okay, let me get onto my... Okay, good. Thank you again for the opportunity to chat to you guys about this. This is obviously something that's very important in our field. And not sure... Yeah, so what I'm going to cover is just a little bit of history, just to give you guys a bit of perspective. I always find it interesting to delve into a bit of background into different fields and that. And I think surgery is probably one of the richest areas with medical history that's there. I'm also going to talk about why one should really become a surgeon, what the qualities are that make good surgeons, because we are different from other specialities because of what we do. I'll go into fairly briefly into what we need to do to become a surgeon, how you could go into a surgical registrar program, but I think Dr. Singh will probably expand on that quite a lot more on what her journey was, and then I think we can answer questions when they arise as such. So if we look at surgery, it really is very old, and if there are even times of the first depiction of a surgical procedure, which looks like quite a painful procedure the poor gentleman is undergoing there. This is already in the BC time period, and this is a circumcision that's being done for an Egyptian. There are also papyrus reeds, etc. And this one again is from BC, and this is actually from China. So it's already, you've got a lot of information coming out of Egypt and China. And then again, this is probably the first proper medical document that has been found, for example, and it's a 45-meter long piece of papyrus reed, and on it they've written descriptions pretty much of trauma. So maybe this is what was happening while they were building the pyramids and the Sphinx, etc., people falling off. And this really is a description of how they manage fractures and dislocations and things. If we look at the difference between a surgeon and a physician in those old days, and when I'm talking about the old days, we've moved to around about the 1300s, even 1400s. The physicians had a proper guild, they had a proper club, because a guild is effectively a society, whereas the surgeons didn't have a formal society. They were actually all barbers, people who cut hair and shaved beards off. So that was already a major difference, is that physicians were already far more academically inclined, whereas barbers just got together and did what they needed to do. In the old days, barbers were always illiterate. And the way that they learned how to cut hair was through an apprenticeship. So they would go to an established barber and they would then watch and see the equipment that he used and how he cut different people's hair and how he shaved their beards, etc. Because there wasn't any academic affiliation to it, these people were called misters. They were not called doctors. But what was central to becoming a barber or a general surgeon in those days was that you needed to be able to use your tools. So it was a very practical kind of thing. And a lot of this has pulled through. So if we look at our training nowadays, I hope that we're not illiterate, but surgical training really is an apprenticeship, because you join a registrar program and you follow what your seniors do, hopefully not your direct seniors, but your consultants, etc. Many surgeons still prefer to be called Mr. I was quite keen on that, and that I wasn't called a doctor. And we're still very practical. Whereas if you look at the physicians, they were always very literate. They had to attend a university, and they actually got degrees, and they were called doctors. And they were completely anti the use of any equipment. It was really just much about brain power and interpreting signs and symptoms and coming up with hypotheses. So you can already see where the difference was there. If we move on to the next slide, just highlighting again the fact that our tradition is that we were actually barbers in the old days. On this slide, you can see I've called it bones, blood, barbers, and butchers, because a lot of what they did in those old days was really what one can call butchery. So, for example, in the picture that you can see there, they're amputating a patient's leg. There's absolutely no anesthetic whatsoever. There's a host of men holding the patient down while the barber actually pulls out his knife or his saw if he had to go through bone, and he works his way through it. And that barber sign that you see with the red, blue, and white stripes is actually the traditional colors of a surgeon, and is actually carried through into today, into modern surgery as well. So if you go to the College of Surgeons in London, you will find that those are the main colors in the foyer, and it just speaks to the heritage of surgeons being barbers as such. If you go to the next slide, I'm just going to go through a few people with some interesting history. So Mr. Poiret, he was actually a French barber / surgeon, and he was really considered as one of the fathers of modern surgery at that time. So it's obviously no longer modern now. But he actually was a battlefield surgeon. So he used to go out to where the various wars were, and he wanted to do this because he wanted to learn how to treat patients and how to manage different kinds of wounds, because his interest was actually managing wounds. And one of his sayings was that I used to bandage patients and God healed the patient as such. But this is probably one of the first people who used equipment to look after wounds, etc. And if you go to the next slide, you'll see pictures of anatomy, and we all know about Leonardo da Vinci. However, the person who probably added the most to anatomy, again, was an Italian barber called Vesalius. And at the time, he was actually called the father of modern anatomy, because he took dissection really to a lot further limits than what Leonardo da Vinci had done. even though he actually followed a lot of what Da Vinci had preached, but he just took it to just a completely another level. And the documentation of anatomy, he used to follow out the arteries and the veins and document very clearly their relationship with the muscles and the bones, etc. If you go to the next slide, John Hunter is probably one of our most famous recent surgeons. He was a Scotsman, and he was also a scientist. And what he's probably well known for, or what he wrote a lot about, was the management of bullet wounds, interestingly enough. And at that time, the way bullet wounds were managed is they used to try and dilate up the bullet tract with various tools. And the reason that they wanted to dilate the bullet tract up is so that all the bad fluids and chemicals that were inside the body had a larger tract to emanate out of. And he actually spoke against that. And his theory was that we shouldn't be dilating and making bullet wounds much larger because of the wound infections, etc., that he saw, especially out in the battlefields. Because often these patients would have their bullet wounds dilated up and then they would go off back into battle, and those wounds would just become absolutely filthy, and those patients used to die from gangrene. And so he actually was the first person who then went and identified what gangrene was. He laid it down to the fact that we were dilating these bullet wounds and sending these people back into war, and he stopped that. And the sepsis rate amongst those patients actually decreased dramatically, so that patients were no longer dying from gangrene of their bullet wounds. If you go to the next slide. So I think we all know about Joseph Lister, but he is probably the first person who really brought sterile surgery to the forefront. He was very strongly for what was in those days wasn't called autoclaving, but it was the beginnings of what we know of as autoclaving. And one of his theories was that if we used clean instruments in whatever procedures we did, the likelihood of infection would be a lot lower. And he actually brought down mortality rates quite significantly as well. He was also the person who introduced wound irrigation, for example, because before his time, people didn't want to put anything into a wound because they thought that one would be contaminating the wound further. And he was the first person who actively rinsed out wounds to wash away the debris and the dirt, etc., in there. If you go to the next slide. So if we start looking at surgical heavyweights, and I think once you start studying surgery, you'll find that a lot of our equipment is named after these two individuals. A lot of surgical procedures and a lot of surgical techniques that we do nowadays were actually described by these two surgeons. Bill Roth is probably the more well-known of the lot. He was also a person who was known for the type of research he did. He was the first surgeon that ever performed successfully esophagectomies, laryngectomies. He had described rectal cancer operations and gastric cancer operations. And probably what's also interesting and not well known is Bill Roth is the person who is known as the father of the white coat. And so he introduced the fact that doctors should be wearing white coats to decrease the wounds infection rates in hospitals, as well as to identify who is actually the person looking after the patient. And in his operating theaters, it was always only the surgeon who was actually performing the procedure who was allowed to wear a white coat, so that everyone knew that the person in the white coat is actually the boss in that procedure. Kocher is also known for multiple things, but he was actually primarily a thyroid surgeon, and he had an incredible low mortality rate in that in his thyroidectomies, he had less than a 1% mortality rate, for which at that time was completely unheard of, because most people had around about a 30 to 35% mortality rate. And the reason why his mortality rate for his thyroid surgery was so important or so low is that he identified that one needed to identify the anatomic structures clearly before excising an organ, and in this case it was a thyroid. And so he was one of the surgeons who really promoted anatomical knowledge together with surgical technique to bring down death rates. If you go to the next slide. So here we see what was in the olden days the operating theatre, very different to what we have nowadays. It was a very small theatre in which there were, as you can see, there was standing room only. There were no real benches there. Those wooden bars that you can see there is where people, the spectators, would observe the operation. And so operations in those days were actually public events. And depending on how famous the surgeon was or what kind of procedure was done, often those lecture halls were actually packed to the rafters with people wanting to watch operations. And unfortunately, if you're also a famous person at the time, you also got a large contingency of people who actually just came and watched the surgery. If you go to the next slide. So here's one of those examples. You can see that the people are all really standing around. The surgeon is in his white coat there. And he's got his knife in his hand, and also, again, it looks like that he's going to be doing an amputation. At the head of the table, you can see who the people who are supposed to be the anaesthetists, dressed nice and formally in their suits, and they probably were using a rag that was filled with ether. If you go to the next slide. So here you can see, in comparison to the previous slides, what is in a modern operating theatre, and as you can see, there's no real standing room for the general public to come and watch, and we have a lot more equipment and monitoring tools, etc. So we have come a phenomenally long way in these 200-300 years since those times. So if you go to the next slide. So if we start going and start talking a bit more about what my topic was actually supposed to be. There are many types of surgeons. I've listed a couple of them there. But there are a vast variety of surgeons. And one of the decisions that you're going to have to make fairly on is what kind of surgeon you want to become. Because most surgical disciplines will have their own sort of training programs. You can do, for example, general surgery and then subspecialize into HPB or upper GI or into vascular, for example. But if you decided, for example, to become a cardiothoracic surgeon, you'd need to go directly into cardiothoracics. The same for neurosurgery, ENT, max fac, etc. So one of the reasons that you need to decide fairly early is, of course, these specialities take quite a few years to complete. There are surgeons around who, for example, would have done general surgery and then gone into plastic surgery. And one of those surgeons you'll come across in your later medical career because he's currently working in plastic surgery. But those are few and far between. If you look at maxillofacial surgery, for example, that is a phenomenally long speciality because you have to do a full dentistry degree, you have to do a full surgical degree, and then you subspecialize in maxillofacial. So those people who do oral maxillofacial surgery are usually subspecializing for around about 10 years if they get into a program directly. And again, for example, if you did urology, you would not start with general surgery, go directly into urology. If you go to the next slide, please. So these are some of the quotes which you'll find on the American College of websites, and it's under the section where you can apply to become a fellow in the American College of Surgeons. And being American, it has a lot of a preamble there. But these are some of the statements and some of the reasons why people say that they became surgeons. I'm not going to read them all through. I'll give you a few seconds to go through them yourselves. But what you get through these statements is that there's immense job satisfaction with doing surgery, whatever type of surgery it is. And it's very different from our non-surgical disciplines where you often have chronic patients and you're, as I say, tongue-in-cheek, and don't mention it to our medicine colleagues, but I call them pull pushers because all they do is they change the tablets of a patient and see what the difference is to the patient. Whereas if we were surgeons and we were managing, for example, high blood pressure, we would just go and excise the culprit organ that's causing the high blood pressure, and that would be the end of the story instead of putting the patient on 4 or 5 lines of medication. But anyway, that's just tongue-in-cheek. If you go to the next slide. So as I was saying, it's job satisfaction. So in this slide, you can see an orthopod is required for that ankle fracture there. There's a hepatobiliary surgeon required for those liver metastases, and then there's a vascular surgeon that is required for that AAA. If you go to the next slide, please. So as you can see, the orthopedic surgeon gets to put in the plates and the nails, and if they do a good job, it is very satisfying because your patient now is able to walk and probably will be able to go back to their normal pre-fracture state, doing sports, etc. If you look at the liver here, through doing multiple techniques of liver surgery in the same patient, we are able to actually clear the liver of all of those metastases. And now all of a sudden, this patient who, if we hadn't done that surgery, would have had a very limited, less than 5% 2-year survival, now actually might have a 40 to 50% 5-year survival rate, depending on how well they respond to the chemotherapy. And if you look at that AAA with that stent that they've placed in, that's an EVAR procedure that the vascular surgeons would have done. Now all of a sudden you've taken away the AAA, so the risk of rupture has gone away. And these are 3 vastly different surgical techniques, 3 vastly different fields of surgery, yet they all are interesting and they all are very satisfying. So if you go to the next slide. So an interesting paper that was published, and I would actually recommend that you maybe get a hold of it, is this paper that is in PLOS ONE. It is a few years ago, but it was an audit where they looked at different surgeons, and they took and these were surgeons who were training to become surgeons, but quite far into their training, early career surgeons, and they also took late career surgeons, so people who are heading towards their retirement ages. And they asked them for factors to promote and to discourage people from actually doing surgery. So if you go to the next slide, hopefully you can see that what I've put onto that slide. But these are the factors that are there to discourage people, although I would put the discouragement in inverted commas. So if you look at the work that we do as surgeons, it usually is quite an extensive workload. We get to work quite early in the morning. We have long theatre days, etc. Our calls are quite busy in the sense that we have to see patients in casualty. We have our ward patients and we have operations to do. Surgery is also very hierarchical, and it's a very good reason for being so hierarchical, is that one needs to be able to make decisions and then follow decision plans. Whereas in other medical fields, there's a lot more openness to discussion around managements, etc. We have a lot of responsibilities. The demands of the work is quite high. And then if we look at the context, training is very important. What is discouraging is if you get into a poor training program, or you get into a training program where the exposure to pathology and techniques is poor, then you're obviously not going to become a very competent surgeon. So again, this points to the fact that you need to start thinking about where you want to do your training and to start finding out where you want to go, that it actually is going to achieve what you need to do to become a really good surgeon. What was discouraging also in this is that there were limited future prospects. In our country, there is a lot of uncertainty around, especially around subspecialization, with our Department of Health and Education not believing in subspecialist programs. So we've had to become very creative around how we fund people who wanted to become, for example, a general surgeon, but now want to take it further and want to subspecialize. And we have to look at that, and we've had to find some creative ways of doing that. And so that is, unfortunately, is a reality in our country. And again, it's something that you need to take into contemplation when you're planning on what you want to do. Surgeons are notorious for poor work-life balance. We tend to work a lot more and live a life a lot less. But that's because I think we enjoy what we do and we are committed to what we do. And again, that needs to be a part of your decision. And again, if you're not able to dedicate a lot of time to your work, to your patients, you're not able to make the fact that on weekends you might need to come in every day and do at least a ward round, be available to take a patient back for an emergency relook procedure, for example, then you should not be doing that field of surgery that you're interested in. Because at the end of the day, if you've operated on a patient, that patient's welfare trumps everything else that you have in your life there. I think I'm going to carry on. Next slide. And so these are the things that promote it. After my negative previous slide, it really, you do get a sense of meaningfulness and responsibility, especially once you start actually operating on patients. You're responsible for what you've done to that patient, and you're responsible for the outcome. And if you achieve a curative procedure, it is phenomenally rewarding for you, and it really does add a lot of meaningfulness to your life. We have a lot of challenges. And we can really become quite creative when we have to start dealing with difficult and complex procedures. We work in teams, and we have to be able to work in teams and rely on our teamwork. There is prestige, although I'm not sure that should really be a major reason why one goes for it. But if you're a successful surgeon, you do have a lot of prestige around there, even though you're not necessarily looking for it. And yeah, I think I'm going to maybe leave this slide there. But as I say, this is quite an interesting paper to read. And if you are doubting about whether or not you should really be doing surgery, I think maybe this is not a bad paper to go and look up so that it gives you a bit of perspective on your decision making. You can go to the next slide. But there's nothing really that beats this. And you can go into psychiatry, you can become a physician, you're never going to get the opportunity to manage this. And this is a situation that if this patient comes alive to hospital, which he did, as you can see, he doesn't even have nasal prongs, there's no reason why this patient should not walk out of the hospital once you've done your surgical procedure. And this is a phenomenally adrenaline-filled procedure, but it is also very satisfying. And it's probably one of the reasons why we do what we do, is because we enjoy this kind of stuff. If you go to the next slide. So this is a very famous algorithm that you'll probably find a lot over the internet. And then again, you can probably put yourselves into that medical student slot in the middle there. And then you just look at the features that you have, and are you crazy? Are you sane? Do you have a short attention span? Are you hardworking? And then you just follow it through, and hopefully it gets you to the surgeon and it doesn't get you into family practice. But I can't guarantee you. If it does get you into family practice, just don't tell your friends. If you go to the next slide, please. So what makes the perfect surgical resident? So this is a cartoon, again, that I took off the internet. If you just go through, if you want to become a good registrar, you must be able to function without sleep. You must be able to function without eating, because you're not going to have much time to do that. You need to have the ability not to need to go to the bathroom for a wee. So either use a leg bag or learn to pinch. You need to realize that you are probably going to become homeless, because you're going to spend your life at the hospital looking after the patients. And if you have a significant other, they're probably going to forget about you. If you have a dog, they might bite you when you come home because they don't recognize you anymore. So just keep that in mind. You will develop a pretty much creepy attention to detail, because it's the small things that make a massive difference. So you're going to learn that when you see a patient on a ward round, you need to look at the Belfic charts, you need to look at the blood results, you need to look at all the different elements of the blood results and then interpret them, because it's a low sodium, if it's missed, is going to have a really bad outcome for your patient if you take them to theatre with that kind of a value. And finally, you're going to lose the ability to feel pain. Your seniors are going to shout at you to a point where you're going to become resilient to that. Because you're working so hard, your feet are no longer going to become numb, they're going to become resistant to pain, and you're going to have a whole bunch of abuse that you're going to get used to. So you're going to lose your ability to feel all sorts of pain, be it physical or emotional. But anyway, this is just all in jest. If you go to the next slide, please. So if we look at the qualities of a good surgeon, if you go to the next slide, you need to be able to work in a team, but even then you still need to be able to be a leader, because if you are the main surgeon around a table, it is your responsibility what happens with the patient. You need to be able to make the decisions. You do need to have empathy, though, because you need to be able to talk to patients because you're operating on them. You are probably the definition of a violator of personal space as a surgeon. So you need to be empathetic and realize the great privilege that you actually have by being allowed to operate on patients. You need to be able to talk to them afterwards. And especially if something goes wrong, you shouldn't hide away from the patient. You need to go and have a chat with them and still be empathetic to them. You need self-confidence, and you need to be able to make a decision. You need to be decisive. So what is the path to becoming a surgeon? So that's the next slide. Well, first and foremost, you have to become a registered doctor. So you need to finish your internship and your community service. You should, during your community service or immediately after that, look at writing your primary exams. Each of the different colleges usually have their own primary exams. So again, you need to start making a decision about which field you're going to go into. And you need to find out from that college. You can go onto the CMSA website, you look for the different colleges that are there, and you look up what their requirements are for their various exams. As a registrar, you're going to write intermediate and then final exams. Once you've passed the finals and you've done your time, you will then become a fully fledged consultant. To become a registered surgeon, you also need to do an MEd degree, and together with the FCS certificate and your MEd, you go to the HPCSA and you become registered, and you can work as a junior consultant. And then you make a decision about, as a general surgeon, if you took, you're going to subspecialize. If you subspecialize, there's different time periods for each. The majority of them are 2 years. There are a few that are 3 years. Again, you need to look that up on the various colleges' websites. And at the end of that, you're going to need to write an exam. If you go to the next slide. But again, as you can see, it is a lot of fun to be a surgeon. If you go to the next slide. So what do you need to do now? I'm not going to go into much detail here at all. I'm going to leave this more to Dr. Singh. But my first piece of advice to you directly is do not make a decision now. You are too young to make that decision now. Rotate through your clinical rotations, observe what goes on, talk to the registrars, to the consultants that are there, see what catches your fancy, and then even do job shadowing, which you can do while you're a student. But also then when you're an intern and a ComServe, if you're starting to lean towards 1 or 2 or 3 directions, maybe then go and speak to people, ask people who are already specializing and working in those areas, if you can just follow them around for a day or 2, or even spend a week with them and see what their day looks like and what kind of procedures they do, etc. And what I can really say is make the most of your elective time, because you'll get a great exposure there. And if you go to the next slide, that is my last slide. I'm going to stop there, and I'm going to say thank you for now.
Thank you, Professor Bryant. I'm sure that everyone has a clear understanding of what it takes to become a registrar now. And now I hand over to Dr. Yonita Singh.
Okay, hi everyone. Sorry, I just want to check, can you see my slides?
Yes, we can.
Okay, perfect. So good afternoon, and thanks again for having me on this platform. Thanks, Prof. Bryant, for inviting me as well. So basically, the fact that you're tuned in, the fact that you're listening, it means that you're sort of considering some sort of career in surgery, and that's already a good start. But like Prof. Bryant said, don't rush into anything, don't make any hasty decisions, and you really have a good few years before you can even make that decision. So as you've heard, I'm a final year registrar in the University of Pretoria circuit. So I'm just going to give you a bit of background about myself. And I finished MBCHB here in Pretoria in 2014. And then I proceeded to do my internship at Tembisa Hospital. So I specifically wanted to go to Tembisa. I wanted to go to a busier hospital. I always knew I wanted to do something surgically inclined, but I didn't know exactly which department yet. But definitely I got a lot of exposure at Tembisa. We all know it's the trauma haven in Pretoria. So yeah, I got exposed to quite a lot of surgical procedures and met amazing people who actually led me to where I am right now. I think if you are considering doing internship at a busier hospital, and then you must try and obviously be more keen and be more active in those surgical rotations as well, just to be noticed as well as to practice things, because you won't really know if you like surgery until you actually do something surgical. Then I proceeded to do my ComServe in 2017, also at Tembisa. At least was fortunate enough to actually do my full year in general surgery. So in internship at Tembisa, the nice thing is in surgery, they actually have something called the minor list and they have something called the septic list. And those are actually internship intern run lists. So you have a medical officer or the HOD himself who teaches you these procedures, and actually these lists run twice a week and you are in charge of it as an intern. So I think that empowers you and sort of makes you feel like whether you're ready or not to do this. In ComServe, it's actually a bit better because then you start doing calls with senior medical officers and other registrars who rotate. And then you're able to actually now start doing appendices, some laparoscopic procedures, and then more important things like amputations, debridements, the common things that we see, as well as laparotomies, which they do let you do in community service already. So it really depends what you want out of internship and what you want out of ComServe, and that will guide your decision as to what hospitals to then put down. So in terms of if you want to be a surgeon, so I'm just going to go through like a general surgeon approach and sort of what I did, is obviously you need to go through reg time. So the reg time in general is about 4 or 5 years, and it really rests on two limbs. So it rests on the M.Med side of it and the FCS. So the M.Med is the university-run degree, so it's your master's degree, and it's research-based. So either you come to the program already with a topic, or you get a supervisor, one of the consultants who will give you a topic, and then you work with them hand in hand, and you start to write a protocol. You attend this TNM course, which I've written there, and that's by the university as well. They help you to sort of draft a good protocol. That protocol then needs to undergo M.Med committee approval. It needs to undergo ethics approval. And in that way, you actually then now start to meet with a statistician. They teach you about data collection, etc. And then eventually you collect your own data. Sometimes you need help from students or other interns to help you as well. But then the point is you're ultimately going to compile a good research project once you've compiled data with your statistician. The end goal here is obviously to write a thesis. Sometimes you can write an article. And of course, one day if it's good enough, you can even publish it. So that's the M.Med side of it. And then the FCS side of it, so that's the Fellowship of the College of Surgeons, as we know, it's by the CMSA. And that really consists of examinations. So the nice thing is I wrote my primaries already in community service, because as you can see, the requirement there is really only 2 years of internship. And it's 2 MCQ papers. It's based on anatomy, pathology, physiology, so your basic sciences. And that's why I say you can write it in community service. Remember, there's exams generally are twice a year, first semester and second semester. So I wrote in second semester of my community service year. So all you need really is the fact that you're an intern, that you've completed internship, and the fact that you've done basic surgical skills. So that's quite a good course to do quite early in internship as well, especially if you want to do something surgical and you want to be able to do things like hand ties and basic procedures. I think the Steve Biko basic surgical skills course is very useful. So you need that anyway to write primaries. Then you proceed to do intermediates. So intermediates, the oral examination is back, and it's also 2 MCQ papers. But intermediates, generally you do while you're in the registrar program. As you can see, it's got quite strict requirements. Some people do come with it prior to interviews, etc. for a reg post, but that just means they've done medical officer time and have had exposure to these different rotations. So generally about 18 months into the registrar program, that's when you'll start to rotate. So as you can see, you need at least 6 months of general surgery, 3 months of ICU time, 3 months of trauma surgery time before you can write this. And then I put ATLS here as a requirement to write intermediates because that's where it is. So it's your advanced trauma life support, which I actually became an instructor in my first year of reg time. I really do believe in the system of ATLS, and I think you should do it earlier. So I did it in ComServe, but actually I encourage people to do it in internship already, because generally you don't know where you're going to find yourself as well. But the trauma system that ATLS teaches you, it's quite simple, it's straightforward, and it really allows you to not miss many things. So it's a good thing to do an internship. It's a 3-day course, and it lasts for 4 years. So at least by the end of that 4 years, you can then just do a 1-day refresher course, and then it's valid for another 4 years. So it's Hi, sorry, it seems I got disconnected. Let me just try share again. Sorry, where did I last stop? Well, when you last heard me?
We were at the slide that had the FSC bullet points on.
Is it this one? Can you see it now?
It's still loading.
Okay.
Yes, it's that slide.
Okay, perfect. Okay, so basically what I was saying is, like I said, primaries you can write in ComServe, and it's twice a year, so either January or July, and then you can choose. All you need is internship and then BSS. And then I went on to talk about intermediates. So with intermediates, like as you can see, the oral examination is back, but it's quite strict requirements. So generally you need a full 12 months in surgery, and then they specify that you need 6 months in general surgery, 3 months in ICU, 3 months in trauma surgery, and then the advanced trauma life support course. So this course generally, like I said, you should try and do it much earlier than just waiting to write intermediates. It will help you. You don't know which hospital you're going to end up in. It will help you definitely in internship. And like I said, it lasts for 4 years. So what you can do just before the end of the 4 years is then to sort of repeat a refresher course, which is just for the day. Sorry, can you still hear me?
Yes, we can still hear you.
Yeah. So yeah, I actually became an ATLS instructor in my first year of Reg time. And like I said, I really strongly believe in the ATLS system. It's quite a basic approach to trauma, and it can help you whether you work in casualty, whether you work in any surgical discipline, and actually just it gives you a good system. It helps you to not miss injuries, and it's quite a basic approach. It's a run over 3 days, but at least when you do the refresher, it's only 1 day that you need to do that. And then finally, you end off with your finals. So here they stipulate at least 36 months of reg time. Ultimately, most of us end up writing at the end of our 5th years and sometimes the beginning of 6th year. And that's generally because of the tasks of completing research as well as studying, as well as working. It's quite a hectic balance that we need to get through. So this numbered registrar training post is what you get when you start in 1st year, and you get that from the HPCSA. And then you need to compile a portfolio over the years. There's a certain number of rotations and specialties that you need to rotate in, as well as keep a logbook of all the procedures you do from the time you start your reg time, and that needs to be signed off by your consultants in that specific firm, as well as keep record of all your academic presentations that you do. So if I can actually just give you a bit of helpful tips that I wish someone had also told me a bit earlier. The point is keep a logbook, and actually you can start early. So start in your internship, already in your surgical rotation, in ComServe, any basic procedures, well, things you think are basic like CVPs, IC drains, already keep a track record of those procedures. Basically, when it comes to your interview, and if you already have this and someone has already signed it off, for example, your medical officers at the time, other registrars, your HOD, if they've signed it off, of course, you can add it to your resume, and it just looks that much better, like you were that much more interested to actually be hands-on and participate actively in your rotations. The other thing is be keen and get comfortable with basic procedures prior to entering the Reg program. So sometimes people are in a hurry to get into the Reg program. I was at least lucky to get in straight after community service, but there's actually no rush. The point is, the more comfortable you are with operating, the better it is for you. So actually, you should try and get comfortable with things like incision and drainage, other minor procedures, amputations, and even laparotomies. Because then when you enter the Reg program, all it means is you're just trying to polish and refine those skills. And now you have that much more time, for example, those 4 years, to now learn bigger procedures, do laparoscopic cases or things you haven't been exposed to. So it's actually not the worst thing to spend a year of MO time before entering the program. The other thing is to get involved with the research. So this just means you can help, as a student even, you can help other registrars, you can help consultants to collect data, for example, for their MMed or their PhD research. And that just means they'll mention you and then say how you contributed to their research. And again, get that signed off. It's something you can add to your resume. The other thing is attending surgical academic events. So you can actually attend academics at any university. Generally, that takes place 2 or 3 times a week, actually. But you can decide what you want to go for. You can go for surgical skills training, surgical workshops, anything to actually just make yourself stand out compared to the next candidate. And then you need to get seniors to write you references. So no matter what you help them with, whether it was helping train other students, other interns, whether it was helping them with research or just being very active in that rotation, get that HOD or someone you work closely with to write you a good reference. And then as Prof. Bryant always says, you make appointments to meet head of departments, surgical consultants, and talk to registrars who have gone through this. I think there's no better way of getting information than from someone who's actually gone through something firsthand. They can actually tell you exactly what it's like, exactly what the expectations are, and of course, what are the opportunities once you're done, because honestly, that's quite limitless as well. So the one thing everyone always asks me, I think I can promise you, I still have a home and a husband. So I know Prof. Bryant said you'll be homeless, but just remember, it's really about striking a balance. Yes, it's going to be long hours. And I mean long, the calls go up to 36 hours, and that can happen up to 3 times a week. But honestly, the more calls you do, the more patients you see. And I feel you learn best from seeing patients. You remember conditions from the patients you've seen rather than just reading it in a textbook. So the more calls you do, the more patients you see, that just means a better learning experience for you. I find if you have more hands-on training, so try and get involved in everything you can possibly at work. If people are short-staffed in theatre, go to theatre, help them out. If they're short-staffed in the clinic, go and help them out. Honestly, that hands-on training is what will set you apart from the rest. And then learn by teaching others. So I love teaching students on ward rounds. That's why I also did ATLS instructing. I like to teach people because it also tests your knowledge at the end of the day. You also can measure up on how good you are yourself. And by teaching others, you're also enriching other people, and they will go on to actually teach other people. The important thing is to know yourself. As Prof. Bryant said, if you're not a person who works well under pressure, who works under extreme adrenaline circumstances, then surgery is probably not for you. If you want a cushiony lifestyle when you're done with community service, it's probably not the best program to enter into. It really is a 5-year sacrifice, the longest and toughest 5 years you'd need to go through. But I always say you'd rather be completely exhausted from tough days that breed success than well rested from actually achieving nothing. So just to end off, I'm going to say it really will be a long journey. And I write there, some days you'll want to quit, but honestly, it's most days you'll want to quit, especially when you start off. You're always considering, did I make the right choice? Am I good enough? Am I in the right place? The point is, if you need to decide, why did I get into this? What is my end goal? And stick to that. From day one, you need to just stick to that. Nothing worth having actually comes easy anyway. And the best thing, I think, is that there's no better feeling than doing what you love with the added benefit of now positively changing the course of someone else's life. And you can see with cancer, you add not only months, sometimes years to people's life. And sometimes it actually means you saving their life at that given time. So the last 2 points there is, I think, something we struggle with as even from medical student days, is you are on your own timeline. I find like in med school, all you try and do is compare yourself to the next person. You try and compete. You need to get it into your mind that you are your only competition. What you need to do is realize that everything is happening in your life the way it's meant to actually happen. You don't need to compete with other people. You don't need to compare yourself with other people. Take your time. Like I said, set goals, set realistic goals, and aim to achieve your own goals. Don't worry about the next person. And then last but not least, you are your only limit. Like I said, focus on what you decided from the get-go. Decide why you're here. And when it gets really tough, just remember, why is it that you're here? Why Why is it that you started in the first place? And remember that you are your only limit.
Thank you, Dr. Singh, for sharing your professional and personal journey with us. We all really appreciate it. We will now give an opportunity for questions to any one of our speakers. You can type your question into the chat box, or you can unmute yourself and ask them yourselves if you want. So we have a question. Is it possible to still have a family life while specializing and as a surgeon?
Yeah, I think I can answer the while specializing, and then Prof. Bryant will answer as a surgeon. So, like I said, I think it's definitely possible. I know Prof. Bryant said you'll be homeless. You won't be homeless, I promise. And yeah, I mean, definitely the point is, like I said, from the get-go, you have to realize what type of person you are. And then you have to set realistic goals for yourself. What do you want during these 5 years? For example, do you want to have a full family and all of that? There's definitely been registrars who have been able to have children. And I mean, most of us are still married, so that's a good thing. There's probably only 2 single people in the department, so that's a good thing. But the point is, you need to balance yourself. You need to understand that your weekends, definitely, like at least 3 weekends a month, that's out completely. So when you have that time off, you need to understand what is important to you. What do you want to do in that time off? You need to set time to study, but and obviously that can't be all the time because you spend the rest of the time at work. And then there's time with family, there's time with friends, there's time to spend with the people that are important to you. Like you've heard, obviously dogs are important too. So you need to spend time with your pets. So the important thing is it all boils down to what do you want out of that? And yes, it's a 5-year commitment, but I mean, at the end of the 5 years, it's over and then you'll go back to having everything like normal. So again, it's definitely possible. Everyone says I managed to somehow balance my social life still. I think my social life's probably a bit too busy sometimes, but it's definitely possible. You need to set study time. You set, well, the rest of the time is work time, and then you set that time aside for the people who are important to you.
Yeah, so I must say I agree with that. I mean, I was saying it as tongue in cheek, but if I look at myself, I have also got a very busy wife. She's also a subspecialist, and we have 2 children, and we have a very busy social life as well. So we are able to balance our lives. There's no reason why you can't, but it is a decision to do that. And you need to obviously find the right person to be your life partner as such. So I did say that with tongue in cheek, but it is a reality and you need to be aware of it. So it's a bit unfair if you get into a relationship and then don't really tell the other person what it actually entails to be your partner as such. Okay.
We have another question. Please comment on the future of surgery. Can SA-trained surgeons work elsewhere?
So at the moment, definitely. Our FCS degree is recognized. What is changing overseas, though, and that's not just because of South Africa, it is other colleges are no longer necessarily accepting them directly into their surgical community as such. So examples would be, for example, in the UK, if you had an FCS SA, you would be able to work in public or private as a surgeon. That's changing, and that's one of the last countries to change. If you wanted to go to Australia, for example, you would need to write their exams. You'd work for a year in an academic hospital under someone's supervision. And at the end of that, you'd need to write the Australian leaving exam. You wouldn't have to do the whole specializing time period. If you pass that exam, you're then registered as an Australian surgeon. It's not because they're looking at the poor quality of South African surgeons. It's not that at all. It's just that they want tighter regulation, and there's a lot more people who are actually moving across the world looking for opportunities. So what they do for one group of people, they need to do for everyone else. So yes, our degree is definitely recognized. Will it change in the future? It's difficult to say. I don't see a reason why it should. The College of the CMSA, which is the home body, etc., is still very strong. It's recognized all over the world. So, and I mean, we work very hard in maintaining standards there. If anything, we've actually increased the standards of our college exam. If I look at surgery, the way we've changed the exams in the last 3 years, we are probably in the forefront of surgical assessment now worldwide. And that's actually been recognized. So, yeah, I don't see why not.
And then we have some questions from the YouTube live stream. The first question asks, Doctor, how would one go about becoming a trauma surgeon specifically?
So that's the same. You would do a general surgery and then you subspecialize in trauma. So you do your general surgery, which is 5 years, and then you'd need to get into a trauma unit that has an accreditation to train subspecialists, and then it's another 2 years after that. But there are quite a few units around the country if you're looking. So, for example, in Pretoria, we can do it. You can definitely do it in Joburg, Cape Town, Stellenbosch. I'm not sure about Bloemfontein. You can definitely do it in Durban, in Albert Lutuli, etc. So, yeah, that's what it would require.
And then another question, what are recommended hospitals as SICs that we should apply for to peds surgery?
Sure, that's very specific now. Well, you just need to have a look and see where peds surgery occurs. So if you look in Pretoria, it's really Steve Biko. The peds surgery unit in Kalafong is being developed. They now have a permanent consultant. They're getting an ICU. So peds surgery in Kalafong will soon be a similar setup to what we have here at Steve. If you look at Johannesburg, Charlotte McKechnie, Chris Harney Baragwanath have it. So that would be a good option. If you look at George Macquarie, they do peds surgery there. Bloemfontein has a very active peds surgery department. Then if you look down into the Western Cape, again, it's going to be Groote Schuur and Tygerberg. And you've got the Red Cross Children's Hospital as well. And then in Durban, you'd have, again, I think it's Albert Lutuli. The problem with these hospitals, though, is they're very central, and they're also the main teaching academics. So the competition for interns to get those kind of positions is challenging. So even if you don't get it and you still want to do peds surgery, there's no reason why you can't go to a smaller hospital. A lot of peds surgery is based on general surgical procedures and principles. So I would just make sure that wherever you go, that you get involved in surgery. It doesn't necessarily at that level need to be peds surgery.
And then Trish are asking, is it better to become a registrar and specialize in SA or in another country? And what does BSS stand for under primaries in one of your slides?
Do you want to take that, Yonita?
So honestly, I think definitely the registrar program here in our country, I think is lovely. And I think a lot of registrars, well, trainees from across also come over here because of the trauma exposure that we have. A lot of exchange programs exist between, for example, like with Steve Biko, Kalafong, and sometimes even Barra, where you get trainees coming from all around the world just because we have that amazing trauma exposure. So I think definitely training in this country is probably the best way to go. The other thing is, in terms of the primaries, I was saying the requirements, you can, I see there's another question, so I'll just address both. You can write primaries, like what I did, is in community service, because all you need is 2 years of internship. And then your basic surgical skills. So that's the BSS. It's actually basic surgical skills training, so BSST. So that's offered at quite a few universities. Steve Biko has a really good course run by the University of Pretoria. So it's, again, a 3-day course. It's teaching you literally basic surgical skills, how to suture, how to hand tie, how to do a small bowel anastomosis, for example. So that you should try and do already at the end of internship if you plan on writing primaries either at the beginning of community service or in the middle of. So there's, like I said, exams twice a year. So the thing that addresses the next person's question as well. Okay. And then we're only going to be doing a few more questions since our time is almost up. And then the one question is asking, hello, Doctor and Prof. Is the FCS SA similar to a postgraduate diploma? Also, which route is easier between MEd and FCS SA? Yeah, so just to be clear, you have to do both. So the reason I put them under two routes on the flow diagram is because it's basically one is research-based and one is exam-based. And that composes your whole registrar training program. But the MEd is when you register with the university, it is your master's degree. You have to do it. And then in order to register as a specialist at the end, you need those three exams. So the primary, the intermediate, and the finals. That's from the FCS, the college route. Plus, then you need your MEd. So that's how you register as a specialist in this country. Okay, and then is there a national ranking for which colleges are the best for specific specialities in South Africa? As Prof mentioned, a better education obviously results in one becoming a better surgeon.
So no, there's no ranking. That would be quite controversial and painful to various departments. I think it's word of mouth. Most of the programs are actually very good. Unfortunately, some of the programs are spread far and wide. So if you, I mean, it's public knowledge. So if you look at, for example, Walter Sisulu University, if you become a registrar there, you're going to be doing quite a bit of traveling. You're going to spend at least 6 months at Groote Schuur. You are going to spend time in East London. You're going to spend time in Port Elizabeth, and you're going to spend time in Umtata. And all of those places are quite far apart. But by going to all of those places, you have a phenomenal exposure to different people and to different pathologies and techniques, etc. So I don't think that there's any program that I would say stay away from at all. It is what you make of it at the end of the day. We do look at these as postgraduate degrees as well. Your undergraduate degrees is effectively your MBCHB. And so we tend to, choosing my words carefully now, we tend to manage people as postgraduates. So what you bring is what you'll get out of it as well. We're not here to hold a stick to your head and say, why have you not done 10 appendixes last week? You only did 4, kind of thing. A lot of it is self-driven, and that's actually what Yonita was talking to as well, is the more you bring and the more keen and the more involved you become, the better and the more exposure you will have. It is very easy to get into a program and then do the absolute minimum, scrape through, write the exam if you study well, pass it, and become a surgeon. But then you're actually cheating yourself, because then you are going to be in a very stressful position when you go out and work in, say, private practice, and all of a sudden you have to manage these patients, but you haven't necessarily had all that experience, and you start sweating if there's complications and things like that. So I don't necessarily think that there's any program that you should avoid. I think they're all good, and I think you need to apply to multiple programs, because at any one time, there's a different requirement in each program, who they need to appoint, etc., and how many people they can appoint. So if you're willing to travel a bit, I would keep your mind open and apply to various ones. But as Yonita said, it's what you bring is what you get out.
And then our last question, is it possible to fast-track training by doing the research arm, MEd, during internship? So your MEd, basically, like I said, you have to register. So when you register in your first year as a trainee, you have to register with the HPCSA, and then you get a training number. So once you get that training number is when you register with the university that you're at, so be it Wits or Pretoria, wherever you are, and then that's when you can only register for your MEd degree as such. So you can do any other research before. So what I was saying is get involved in research in general before that, just to put on your CV and just look like you've actually taken the time to get involved. But with MEd specifically for your master's degree, you need to be registered as a registrar, and that's when you start in your first year to start working on your own MEd project. Okay. Then that's all the questions we have for today. I would just like to thank our speakers again for the very interesting and insightful talk. And I would also like to thank everyone who joined us today. and just ask that you complete the Google form that we sent in the chat box, just to provide us with some feedback on our lectures. And yes, that would be the end of this lecture then. Thank you very much.
Good. Thanks very much. Have a good day.
Thank you.
Thank you.